yesterday. So, we will be today, we will I will be just highlighting the need for the investigations which we have for certain like just a second, please. Just tell me one thing. Usually, if you have Azhar, would you like to speak out? Azhar, am I audible to you?
Sir, please.
Yes. So just keeping an
Sir, you're
example.
audible, please.
Yes. So if I just give you an example of a scenario, and then you tell me which investigation would you like to have. For example, you have an emergency appendectomy in a 18 years old female. What investigation would you like to have, and what will be the reason for those investigation?
Sir, Assalamu alaikum, sir. Bismillahirrahmanirrahim. My investigation definitely will depend on the clue from the history and related physical examination. Uh, uh, Usually, it's hemoglobin and blood CP is done to see the patient is anemic or not. And
Okay.
TLC count is important to rule out any infection or definitely appendicitis is an infection. So it is expected that TLC will be increased.
Okay, TLC
Other
actually
things
in
would
some part of world
uh,
TLC will not
other
be
things.
understandable. So it is actually TLC is total leukocyte count, or in other part of world they say WBC. Okay. So WBC
Sure,
count
sure.
you are asking, then what else?
Uh, Platelet count is also important. There may be a thrombocytopenia. We expect normal platelet count
Platelets,
around
just
ten
just hold
thousand.
on. Azhar, just hold on. In a patient with 18 years old female, no other comorbidity, will there be a chance of platelet counts?
Less likely, very less likely.
Okay. But as a part of CBC, it will come. Okay. But your
Yes,
main
yes, sir.
focus, anything else other than WBC is important in a 18 years old female?
Um, in blood CP, you are asking only for blood CP.
Yes, yes.
Um, so mainly we focus on these two things.
In this age group, anemia can be there because of any menstrual problem. Okay.
It's
So, so
Essentially I told for
hemoglobin,
hemoglobin, sir.
hemoglobin. Okay. With reference to that thing.
Priority will definitely will be hemoglobin.
Okay. Anything else?
Yes, sir.
Anything else? Like you will
Well,
be looking at
on the
WBC.
ultrasound, ultrasound.
Try to finish the lab works before going to ultrasound. Any other labs would you
Okay,
like to
okay.
see?
Uh, just to rule out UTI, I may see for may go for
What about
urine
beta
RE,
HCG?
DR.
What about beta HCG?
Definitely. That is because patient may be pregnancy test may be positive. So simultaneously, I will look for the this thing and ectopic pregnancy. To rule out the ectopic pregnancy, I will go for beta HCG, sir. And definitely, well, that clue can be get from the ultrasound as well.
Yes. Okay, so you were saying ultrasound. What other investigation would you like to see with reference of appendix, other than now it is open? Like, would you like to have CT scan? Usually, appendicectomy is, of course, is not in our
CT in
setup.
the last when the
Ultrasound is
appendix
usually
is diagnosis obscure, then we may go for the CT scan.
actually it is like one of the diagnostic tool with reference to appendicitis.
Sir,
So, what else can be done? Like in ultrasound, maybe there may be like free fluid, appendicular mass,
sir.
or ruptured this appendix. Okay. So usually you will not need
appendicular
any other,
mass.
you will not need other investigations in this setting. And actually you don't, you, of course you will be discussing with the surgeon how much because maybe if it is already ruptured, you don't have time for too much investigations. Okay, if they have made a diagnosis clinically with reference to the all the test clinical test, maybe you have to proceed with it. Okay, so I'm just to give an insight. So usually what other investigations we come across during our routine, for example emergency, because I'm before going to for
Sir,
cases, any elective cases, usually the investigation which we see is CBC. Okay, LFTs. In emergency, it will take some time, but even then, uh, what else? What else you can do immediately with reference to urine? Okay, the urinary for any like ketones. Okay, what else? Blood
sir.
sugar, blood sugar, blood sugar level,
Blood sugar. Yes, sir. There may be a element of UTI in which WBC and
electrolytes.
electrolytes and so protein would be important in protein urea would be important in the urinary or not?
Yes, in urine RE, if you yes, Atif, you raised the hand. Would you like to comment anything?
Yes, sir. Sir,
Yes.
we started talking about that patient, the female patient who is
No,
18 years old and now
no, no, no,
presented for.
no, no, no. We have now. I'm just expanding. This was just
Okay,
to
now it's
start the discussion.
general discussion. All right,
Yes.
sir.
Now we are just. I'm just trying to. It was just to start. Now I'm just trying to, because usually we do the investigation without any reason. Okay. Like for example, in the for and this is very important with reference in the exam. If for example Azhar will tell in the exam that I would like to see in a female without any history platelet count, it's not wrong answer, but it is an irrelevant answer. Okay, but for every point we have to give an explanation. Okay, so now I'm just trying to expand our interpretation, that in which conditions would you like to see serum electrolytes. Now just for example, to start with, just Azhar, try to think in which conditions we would like to see electrolytes. Just focus on this. I'm sorry, can we mute? Yes, Azhar, in which condition would you like to see electrolytes?
Sir, patient,
CRF?
if patient yes, CRF or patient is for example on any drugs that may cause hyperkalemia, that definitely history will tell, and patient may be using a diuretic, so hyperkalemia would
In
not.
it, if you want to make your life simple, you can divide it in with the form of diseases. Okay,
Sir,
or in with the form of medications.
sir,
Okay, so if you want to think about medications, you can tell about diuretics. What else
sir.
can change the electrolytes? ACE inhibitors. What about beta blockers or beta agonist? What else? Lithium effect on sodium. Okay, you can think a lot of
Forget
things.
goes
You
for
can,
lithium levels if the patient is already taking.
yes, so you can have, I'm just, because we are not discussing any specific disease, we are just trying to have our brainstorming, that why would you
Sir,
like to
sir,
have electrolytes. Okay, so maybe whenever whatever
sir,
condition you will have, there will be some reason. It is either it is because of any disease or it is because of any medication. Okay, So now you can think about it like, for example, any endocrine problems with reference to which two hormones can create problems with the electrolytes with reference to brain. One is ADH, okay,
Aldosterone.
Aldosterone.
aldosterone. Okay. So any disease in which there is any problem with ADH or aldosterone, any medication which is acting on ADH or aldosterone, or any condition which can cause, so there will be problem with either sodium or potassium. Okay. What other condition other than disease, any like, for example, if we have a trauma, so you can think about hyperkalemia with reference to rhabdomyolysis. Okay. Or if there is head injury, then of course there can be problem in sodium, okay, in the form of SIDAH or cerebral salt wasting syndrome, okay, or like in certain neurological problem, diabetes insipidus as well, which will be related to in the form, in one way or other, have some relation with ADH or aldosterone. Okay. So like this is again I'm telling you, sometimes if you know how to use different scenarios and different condition, you will not miss it, because there is no other way that if you try to recall a page from a book and try to answer the question which are being asked there, you in the written exam you can do it, but in the oral exam, if you don't have the practice, if you have not done this brainstorming, I can guarantee you cannot answer. Okay, because you will say irrelevant things and you are not able to defend. Okay, because the usual theory is that in the exam, if you commit something and you are, if even if the correct thing you are not able to defend, you will fail. And even if you commit something wrong but you are able to defend by somehow, by some of your justifications, you will pass. This is what we do in our actually, this is the mistakes which we do, which lead to our failure. Okay, because in the exam you have 5 minutes to answer something which you have read for 5 months maybe, and the examiner have only 5 minutes to evaluate you. So if you don't have the knowledge on the business end, you cannot defend yourself. Okay, so this is, and for the junior residents, if you practice this thing from the very start of your career while doing preoperative assessment, if you try not to follow any like specific routine without any reasoning, that you are doing, sir, we are doing routine test. So if you are in a habit of saying routine or baseline, this you are burying your grave yourself, because you will have no concept, and in the exam you will fail. Even if you pass, you will have no understanding. Okay, so this is very important, that whatever investigation you are doing, you should have a reason for it. Okay, so like I'm just giving you an idea, and of course in this will be beyond the scope of one discussion to have brainstorming for all the investigations, but I will try to give you as much as possible. So think now, think your brain, maybe you can add on what investigation, what reasons you need to have some electrolytes. Okay, so you will think that all the things will be related somewhere near to the kidneys, CRF, ARF, or anything which is creating problem with the kidneys, so it can cause, or any hormone imbalance which is creating problem with reference to potassium, sodium, and then some other things will be related to calcium and magnesium. Okay, so either it will be some iatrogenic. Okay, like usually just this is we have discussed before. Usually, whenever there is any problem with the electrolytes, either is the problem with the excretion. Okay, either it is a problem with the compartmental shift, or there is increased intake. Okay, so usually these are the things in where, I will request all of you to mute your mic, please. Okay, so like there will be something like other way around, just we will go to the next investigation, but with reference to diarrhea and vomiting. Again, there will be problem with the potassium, chloride, sodium, okay, bicarb. So like this condition will be there either in the form of gastroenteritis or intestinal obstruction. Okay. So I'm sorry, this is creating a little bit of intestinal obstruction or anything which is causing vomiting. It's okay. So there will be implications. So now if the next part of which I just wrote in my message, you should be knowing why you are doing that investigation and what implication will have. So you know very well what will be the problems with reference to potassium or with calcium or with magnesium. Okay. You can have a lot of problems with reference to cardiac problems, with reference to increased duration of neuromuscular blockers, some arrhythmias, even cardiac arrest, respiratory problems. So you can just brainstorm yourself. And with sodium, unconscious, usually sodium with the brain. So sodium will be related to with the conscious level and problems related to neurological system, and potassium, calcium, magnesium will have more effect with reference to muscles. Either it is cardiac muscle or it is peripheral muscles. Also, phosphate will be there. So, like this is just we are not discussing any specific topic. We are just trying to groom our mind that how we have to approach. Okay, because these electrolytes, you have a look at it and you are only looking at normal, but you should be knowing if it is abnormal. It's not only matter of correcting it; it's a matter of knowing the result for it. Okay. And will the trend will be going towards the lower side or higher side. If you are inducing the patient, maybe you have potassium of 4, but you have to give, for example, succinylcholine, it can increase. Or you have 3.5 and you are expecting a lot of loss, so maybe potassium will be losing even more. Okay. So this will also affect the fluid which you are using. Okay. Maybe you will be choose about ringer lactate or plasma light. Okay. Or like sodium chloride or dextrose water. So these electrolyte will make you either be careful from something, changing your management plan, fluids, and even outcome of the patient. Okay. So that's why electrolytes will be important. Similarly, if we just have a look on, like we started with the hemoglobin and hematocrit. Can anyone explain the relationship between like hemoglobin and hematocrit? For example, if hemoglobin is 10, or in some units it's 100, how much should be the accurate hematocrit? Yes, Azhar? Yes, Atif?
Sir, kindly ask again. I missed something.
If hemoglobin is 10, what should be the hematocrit?
30.
Okay, it should be 3 times. So if for example hemoglobin is 10 and hematocrit is 27, what does it mean?
Low mean corpuscular volume.
No, but what will be the reason clinically?
Uh, just a guess, sir. Iron deficiency anemia
No,
may
no, no, no,
cause
no,
it.
no, 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 no. It means patient is hemo concentrated.
Hemodilution.
No, hemo concentrated. When you will give
Sorry,
fluid,
hemoconcentration.
the hemoglobin will come 9. Okay. And this is the most common finding which we have usually. Okay. Usually when we are managing the patient, this is the most common finding which we face. Even it is maybe hemoglobin will be 12 and hematocrit is 24. Okay. So when you will give fluid, because patient is dehydrated, so when you will give fluid, immediately the hemoglobin will fall. So interpret it. The other way around can be there, but usually it will be, this is more common thing which you can face, especially if you are dealing a case with trauma or any bleeding patient. Okay, understand? Any query? If you don't understand, let me know, please.
So, sir, hematocrit would fall first in case of a trauma patient, but hemoglobin will fall after we give the fluid.
Yes. Okay. So like usually it is the interpretation which you have to do. Similarly, with reference to hemoglobin, which other diseases in which you have some problem like this? Methemoglobinemia. Okay. Then sickle cell disease. Okay. Thalassemia. So any other cause of, for example, anemia, you have to, like in sickle cell disease, you have to have some details about the hemoglobin, like hemoglobin electrophoresis to see the or sickle dex test for the sickling and hemoglobin S levels. Okay, and in the premature babies or any condition, you might have to see the hemoglobin F. Methemoglobin, you need to see the levels. Then carbon monoxide poisoning. Okay, in carbon monoxide poisoning you need to know the carboxyhemoglobin levels. Then you can just think about with just think in detail, a little bit detail about hemoglobin, that what different form of hemoglobin or more details of hemoglobin you need to know in certain conditions. Okay, so because that will tell you the transfusion triggers. So usually in a cardiac patient, we say that it should be around 10. Okay. And in non-cardiac patient, it can be around, for example, 7. In different scenario, it will be different. If a patient is constantly bleeding, then you will not wait for the hemoglobin to fall down. Maybe you will give earlier, because even if you are giving the blood, maybe the hemoglobin can fall. You can see that one time you see the hemoglobin is 8, for example, and you can see that patient is still bleeding. You will not wait for hemoglobin to fall to 6 before you give the blood. You will give the blood. Okay. So this is just a clinical interpretation which you need to, sorry, the clinical judgment and interpretation of the situation, which is important for you to judge it. Okay. And just few words about, of course, you can do the CBC before, but there are certain ways in which you can analyze. There are certain now advanced machines which are indirectly the Masimo. There is a monitor, and there are certain which are non-invasively telling you the hemoglobin concentration. You cannot rely 100% on it, but it will give you a clue. And maybe if the trend is going down, you can just follow the trend. Okay. Of course, there will be other sign symptoms with reference to hemoglobin as well, but this is how you will interpret, because there is a concept of point of care testing. Okay, because not all investigation you can do inside the operation theater, but hemoglobin or hemoglobin analysis is some of the things which you can do inside the OR. Of course, with the ABGs, okay, but also as I told you that there is a monitor company with Masimo, in which non-invasively it is telling you the concentration. Okay, so you should be preoperatively, and again preoperatively, maybe one single reading is not reliable. Maybe patient is having 10 hemoglobin, but patient has received 4 units of blood maybe in last 24 hours. So you have to interpret maybe the serial readings before operation with reference to hemoglobin. Okay, so there is no single word answer or single spot diagnosis for you. You have to see the overall scenario, overall condition. But usually these are the things which you should be considering whenever. And as I told you, hemoglobin and hematocrit, this is a common mistake which people do. They only look at the hemoglobin and they never look at the hematocrit. So hematocrit, make your habit in a way that you see hematocrit first rather than hemoglobin. Tune your brain. If you have ABG's machine or even in the CBC result, try to have a look on the hematocrit first. I do like that. Okay, so this is one thing. Then of course WBC, platelet count, they have limited scope. WBC, it is more important with the reference to ICU, but usually if you have a high WBC count, you are expecting an infection. And platelet count, similarly, there will be some reasons for low platelet count. Either it is acute or it is chronic. Again, platelet will be related to either disease or medications. There are certain medications, you can make a list of the medication which can cause thrombocytopenia. Okay. What will be the importance of thrombocytosis? Can anyone tell? If you have high, I'm sorry, what did you want to repeat? KJ Balushi, I don't understand which thing you want me to repeat. I can repeat it. I just saw your message now.
I think she was asking about the hematocrit.
Hematocrit. What exactly you want me to tell? With reference to hemoglobin and hematocrit, it should be 3 times. Okay. And you will look at the hematocrit. For example, if it is 30, hemoglobin should be 10. If it is less than 10, it means patient is hemoconcentrated. Okay. I hope you are clear now. Is it clear now? It should be in three times in either direction. So yes, can anyone tell what will be the implication of thrombocytosis? Yes, Azhar. Or anyone else? Anyone want to answer this thing?
Sir, there will be a pain, thrombocytosis. There will be pain.
Maybe malignancy. Maybe because of malignancy.
Okay, reason whatever may be. What will be the implication?
So it will cause a hypercoagulable state. So
Yes. So may this patient, again, maybe this patient is dehydrated. In dehydration, it may be a wrong finding, but now you have to maintain the volume status. Okay, even because if thrombocytosis is there and you keep the patient dehydrated, the chances of thrombosis will increase. Okay, so any patient with thrombocytosis, you have to maintain the blood volume, the volume status, and maybe you can consider to have a more aggressive thromboprophylaxis than any other patient. Okay, so this is just a small interpretation. There are certain other parameters, CRP, ESR, okay, then eosinophil count. So they will be either with reference to like any immune process or allergic process, okay, respectively. So this may be in front of you. What will happen to hematocrit when fluid is given in case of trauma? Hematocrit will have less effect. Hemoglobin will fall, okay, because hematocrit is the total mass of RBCs and hemoglobin is a concentration. Okay, so if you have, it is just like making a drink. If you are making not other drink, ruafza or what we drink. So if you will have less water, it will be more concentrated and it will be more sweet. So similar thing happen here a little bit. I hope you understand. Okay, so there will be not much effect on hematocrit. Hematocrit will fall and because hematocrit is already, as we mentioned, that hematocrit is already low. Okay, so of course if you are giving too much fluid, then you are making dehydrate like hemodilution. So the things will be according to that. Okay, so similarly, like these are the things. Well, now just to have a look on LFTs. What usually would you like to see with LFTs? Usually it is either synthetic or what else? Damage
exactly damage. The enzymes will be
and
raised because of.
on obstructive. Okay. Usually there are three things which you might be seeing when you are having a LFTs. Okay. So of course, in the synthetic function, you will see albumin, you will see INR. Okay. And the hepatocellular damage, you will be looking at
ALT, AST.
ALT, AST, gamma GT. Okay, so things like that. And obstructive, it will be either in albumin. Actually, albumin, sorry, bilirubin is there in almost all of them as well, but usually alkaline phosphatase and like bilirubin here more. So you just need to interpret your findings accordingly. And of course, anything which is creating hyperperfusion, if the patient remains hypoxic, hypovolemic, vasoconstricted for a long time, there will be changes in liver function. Okay. If a patient is receiving any medication which can cause liver damage, there will be liver dysfunction. If a patient is taking, for example, long term, there will be, you should be knowing the group of medications which are causing some. Can you tell some of the groups? Anti-tuberculous medications, anti-epileptic medications, okay, chemotherapeutic agents. So these are example of few of the medication which can cause liver damage or liver, and of course the diseases which will cause synthetic problem, either it is acute liver failure or chronic liver failure. This is again a detail of knowledge which you should have, but we are just trying to. And other investigation with reference to like liver will be ultrasound. Okay. So like you can interpret, and again, electrolytes will also come here as well. Okay. Because there are massive change in electrolyte with reference to liver dysfunction. Okay. So what about urea creatinine? Usually this is one we are looking at. So how can you interpret urea creatinine? I'm sorry. Sulfur drugs. Sulfur drugs for what thing, brother?
Liver.
I'm sorry. I don't understand. Actually, this is window. I can liver
Sir, I
damage.
think liver.
Yes. Anyways, so can you comment about urea and creatinine? Yes, of course, we say that if creatinine is high, it is CRF, and urea can also be high in CRF, but if, for example, there is acute renal failure or there is dehydration, there will be changes in urea. Okay. So because you have to interpret, if for example you have a patient with high creatinine, it means that patient might have like chances of, you will avoid what will be the interpretation, both for liver and kidney, you all medications which can cause further damage, okay, or metabolized or excreted, you have to give with caution. Okay. There are certain things which can damage the liver or kidney, and there are some things which are dependent on liver or kidney. So the example will be, for example, paracetamol. If the patient liver function is not good, you might need to, or either avoid it or to decrease the dose. Similarly, for example, pancuronium,
And
okay,
they
pancuronium
say
or rocuronium with reference to liver. Okay. Pancuronium, rocuronium, they are metabolized and excreted somehow. With rocuronium is excretion through the bile as well. So you should be thinking about it. What you will be trying to consider cisatracurium in both renal and this, and of course, as you mentioned, NSAIDs. So you will avoid NSAIDs in patient with renal failure. Okay. Or for example, you will try to avoid any medications which are changing electrolytes, like for example potassium you will be taking care of, especially if you are, for example, giving magnesium sulfate and the patient does not have the urine output, or patient has depressed renal functions. This can create serious problems because magnesium is being excreted through the kidneys. So if that's why an additional thing which I just came to my mind, so I will just tell to you that magnesium, uh, don't give magnesium if the urine output is not there. Okay. Similarly, don't replace potassium till the time you get urine output. Okay. Because like this is the same theory which we do with in the management of DKA. Usually we start with normal saline and we start with insulin and we wait for the urine output. As soon as patient starts having urine output, then we add potassium. So this is how we proceed. Okay. So, I was thinking to finish this in one discussion, but I will continue from here. And I hope you understand, because, this is the chunk of your anesthesia practice. If you have very clear concept about like electrolytes, and I just wanted to show you something. This is there in the link, but I will share it again. There are certain guidelines for having these all preoperative investigations. So inshallah, same time I will try to continue our discussion tomorrow. Okay. So any question? I hope you understand. And
Yes, sir, just one question, sir.
sure, sure.
Is it the same for calcium also?
With
If
reference
there
to,
is no urine output, if there is no urine output, we should not give magnesium or potassium. So is it the same for calcium also?
I think for calcium it is no. Calcium you can give. Just correct me if I'm wrong. Anyone, please. You have a very good question. I will try to search the answer, and please do join tomorrow. I will try to answer this question. You have a very
Okay,
interesting
sir,
question.
inshallah.
I think, but usually we don't. I have not heard any problem with calcium. Okay.
Okay, sir. Thank you so much.
Okay. So thanks a lot, all of you, for joining, and I hope it was bit beneficial. Azhar, I want to listen from you more. Okay, so we will continue from here, and we will have I will just try to have some words about ECG, chest X-ray, echo after finishing this lab works, and then maybe in next third discussion we will try to go to individual diseases investigations. Okay, so I'm uh, giving you, I am discussing a topic which you will not find in any book. Okay, so um, thank you, Dr. Said. Remember one thing, uh, where to read today topic. Actually, if I find from where to read, because this is your brainstorming. This is not specifically, I am not opening any book. I am not reading any book to tell you. Okay. This is just even some things I'm just thinking, like a question which he asked about calcium. I never thought about it. That's how I am. When I say thanks for all of you to join, this is the reason. Because remember one thing, uh, learning is from, it should be there to the last breath. Okay, because the day you claim that you know everything, you will start falling down. So try to learn everything, and try to think that this learning and teaching is just like a worship. Okay, because if you want to help others, you have to, the result, the best way to for teaching will be that you will never forget that I passed my exam in 2013 14, and I had some international qualification which I was doing, taking for a few more years. But since 2017 I have never touched books. And if, for example, if I can recall a number of things, it is only you people are the source for me to have this knowledge. So I will request you, come out of, and again I will tell you that come out of the books. Okay, because books you will give you only a tunnel vision. This is the link. Okay, so this is in the link which I share a number of times. If any one of you who is listening doesn't find this link, let me know. I will, but this is in the articles and tutorial topic wise, and you will find in perioperative care, you will find preoperative preparation. Okay, so whatever I found, some guidelines, some nice guidelines, some whatever preoperative testing you need to know, you can have a look here. I had just made a list of the topics. Just a second, please. So it was, this was made by me. I was just thinking what we should need to know about in different conditions. So you will find it in the like how to study folder. It is how to approach patient. This is another in the same link. You will find this Zishan anesthesia data. You will go inside, and then one is for articles and one is for the other things. And here you will find some of the things which I'm showing you to you, like surgical list. Yesterday we just try to have an approach, how to approach a patient. Okay, so all of you are welcome to ask anything anytime. Okay, so thank you very much, and we will meet tomorrow inshallah same time. Assalamu alaikum warahmatullahi.
Thank you so much.
And thanks Dr. Munawar for coming. I wish
you.
that you invite other people as well, instead of only having a nice walk. I know that you join whenever you are having a walk. So now I know this. Bye bye.
Thank you. Allah Hafiz.